and the experts. I'll request Professor Datta to start the proceeding.
Thank you, Dr. Shapon. Even in spite of having some problem with you're not so healthy. I think you're sick, having unwell. And on my request, you have joined. Thank you for joining. And I welcome all the participants, attendees, and the presenters, Dr. Bhutesh and Dr. Arpan. The mentors, I think Dr. Shivendu has not joined, Dr. Deepshika, and of course the experts. So, experts are there. Today's experts are Dr. Taruknath Ghosh and Dr. Deepshika. So, the first speaker is our Sabir has not joined. Sabir joined, no?
Yes,
Sabir has okay, yeah. And today's the case is a case on hematology. We had a series of cases the last 6 months. So, neurology, nephrology, and cardiology, rheumatology, oncology we have finished, and this is a case of hematology. Will be discussed on the different cases. Totally, it will be clinical based discussion approach to a case of hematology, and it will be beneficial for the postgraduates and trainees and the practicing pediatricians. So I'll request the experts, if you want to say a few words, and request the mentors to introduce the presenters. I think the experts only Taruk and Deepshika is there. Dr. Taruk. Unmute yourself. Unmute. Taruk, unmute.
Thank you, madam, for your kind introduction. Now we are going with series of Sandhya Pathshala, and most of the topics are well covered. And now today's topic on hematology. Today we have two cases probably. One from our Bardhaman Medical College and from another from Medical College Kolkata. And our student Dr. Arpan Satpathy will present a mysterious case of anemia, and Dr. Shubhendu is there or not?
Shubhendu yet to join.
Oh, Dr. Shubhendu De is one is mentor. Actually, the case is from his unit. Huh? Okay.
First case will be
thank you, madam, for giving me the opportunity to this program. Thank you.
Okay, so I think Dr. Sabir, will you please share your presentation till we have some introductions? So Dr. Sabir is a second year postgraduate resident in Calcutta Medical College in the Department of Pediatrics, and he's going to present a case of hematology, and the mentor is Dr. Bhutesh Das. He is a senior resident in our college, Medical College, Kolkata. Dr. Bhutesh, please introduce your presenter and say a few words before starting the case. And yes. Sabir, you make it a slideshow.
Yes. Thank you, ma'am. Now we'll be starting another episode of Sandhya Pathshala, and we'll be going for a case of hematology for this presentation. So now we will be actually our second year resident, Dr. Sabir will be presenting one of the common cases that we get in our regular day-to-day practice and in our residency. And if we think about hematology, we cannot think of hematology without thinking about this case or this type of disease. So I will not say much about this. Rest is for Sabir, Dr. Sabir. I am handing over the screen and
good evening to all the organizers, faculties, and seniors, and all my colleagues. I am Dr. Sabir Ahmed Mullah, second year pediatrics, PGT of Medical College, Kolkata. Today, I will discuss a very common case that we commonly encounter in our in any pediatrics ward. I will discuss the history taking, clinical examination, and brief overview of the pathology and the principle of management of this disease.
Dr. Sabir, can you increase the volume a bit?
Yeah.
Otherwise, it's okay, but if possible, to increase a bit the volume. Continue.
So, Our patient Sudeep Gope, a 4-year 6-month-old male child from Purulia, admitted on 11 July, presented with gradually progressive abdominal distension for last 1 year and upper abdominal pain for last 7 days. There was gradual distension of abdomen since last 1 year. It was progressive in nature and it was not associated with puffiness of face or pedal swelling or decreased urine output. There was history of pain in the left hypochondrium region for last 1 week, gradually increasing. It was gradually increasing, diffuse in nature, and not radiating to any other side. There were no relation with food intake or decubitus change. There are no history of vomiting or constipation or hematopoiesis melena or yellowish dispersion of urine. There was history of easy fatigability. There are no history of respiratory distress or chest pain or palpitation or fever, recurrent infections or any bleeding manifestation. There are no history of headache, bone pain, decreased appetite or any significant weight loss. When you look at the past history, the child was a diagnosed case of chronic anemia and received blood transfusion at 6 to 8 weeks interval since 8 months of age. Transfusion frequency has increased over last 1 year. Now the patient receives blood transfusion at 2 to 3 weeks interval. The patient was not on any other medications. There were no history of hospitalization except for blood transfusion. This is the pedigree chart showing the family history. The child was born out of a non-consanguineous marriage. Index is showing our patient and the other sibling, who is a 7-year-old male child, was unaffected. Both the parents were carrier according to the history. Antenatal history, birth history, and postnatal history were uneventful. Immunization was up to date. Patient has not received any vaccination outside. Development history was normal. The patient was exclusively breastfed till 6 months of age. No top feeding was done. Complementary feeding was started at 6 months of age. This is the 24-hour dietary record of the patient, which shows total calorie intake of 895 kilocalorie and expected calorie intake was 1350 kilocalorie. So there is deficit in calorie intake, but there is no deficit in protein intake. Personal history and socioeconomic history were unremarkable. So to summarize the case after history, Sumit Gope, a 4-year 6-month-old male child from Purulia, born out of non-consanguineous marriage, deficit in calorie intake, was a diagnosed case of chronic anemia with repeated history of blood transfusion at 2 to 3 weeks interval, presented with history of gradually progressive abdominal distension for 1 year and diffuse pain in the left hypochondrium for 1 week, which was not associated with any vomiting or constipation or yellowish discoloration of eyes and puffiness of face or pedal swelling. Should I continue? Sounds Am I audible?
Yes, you're audible.
Next, we come to the general examination of the patient. First, in the vital parameters, all are within normal limit except for high volume pulse. This is the anthropometric data of the patient, which has been elaborated in the next few slides. The weight of the patient was 12 kg, which was between minus 2 HD and minus 3 HD, which belongs to underweight category. Weight age of the patient is 2 years. This is the height for age curve. Height of the patient was 97 centimeter. It was between minus 2 HD and minus 3 HD, which belongs to standard category. Height age is 3 years. This is the graph showing weight per height, which is between minus 2 HD and minus 3 HD, which belongs to wasted category. Mid upper arm circumference was 11 centimeter, which belongs to minus below 3 HD, which suggests severe acute malnutrition. On general survey was unremarkable except for presence of pallor. Head-to-toe examination revealed no skeletal changes. Here we examine the gastrointestinal system. In the upper alimentary tract, there was no signs of any micronutrient deficiencies. Next, we examine the abdomen proper. In the abdomen proper, on inspection, there was a distended abdomen was distended in the upper 2 quadrants. Umbilicus was inverted. On superficial palpation, there was no abnormality. On deep palpation, there was 8 centimeter smooth, firm, sharp, regular liver palpable below right costal margin in mid-clavicular line. On there was a smooth, firm, 40 centimeter smooth, firm, sharp, regular spleen palpable below left costal margin along its long axis. Percussion was revealed no anomaly. Liver span was 12 centimeter. Upper border liver donus was at right intercostal space. Auscultation was normal. External genital revealed no abnormality. Parectal examination was not done. Cardiovascular examination system, respiratory system, and nervous system revealed no abnormality. So to summarize, after examination, on general examination, the patient had high volume pulse, visible pallor. He was underweight, wasted, stunted, and severely malnourished. On systemic examination, the patient had distended abdomen with divided umbilicus and significant hepatosplenomegaly.
Dr. Sabi, just wait.
Okay.
I think I request the experts to ask the questions and say words and about. And in summary, you have not included the history part also. There's a history of blood transfusion that should have been mentioned in the summary. When you're summarizing after examination,
The history of summary is previously told.
huh?
History. Summary
Yes.
of history he is told previously.
Summarized the history in the previous.
So it should be
Okay,
when you
okay.
do the final summary, it should be both your history part and examination part. Okay. For the summary of history you have given most probably, and then summary of examination. The summary means whole thing you have
Whole
finished
thing.
after taking history and total examination. That will be the summary.
Okay, ma'am.
Okay. So I invite Dr. Taruk and Dr. Deepshika to ask questions, modify, whatever you want to just do the session. Session is yours.
The patient, the child got regular blood transfusion. I think.
So, Dr. Sabir, good presentation. Can I come in, ma'am?
Yes, Dr.
Yes,
Deepshika.
yes.
One by one, huh? First Dr. Deepshika, then Dr. Taruk. Okay.
Okay, thank you, ma'am. So, Dr. Sabir, good presentation as such. But a few points I would like to mention, like in the history, especially in the negative history, you haven't mentioned any progressive pallor, which should be in the history or the negative history to begin with. And the second thing in the examination, like this looks like under transfused chronic hemolytic anemia, probably thalassemia. In your examination part, it's a little difficult to believe, like your CBS examination, the apex you have mentioned in the fourth intercostal space. Usually they have dilated heart. So like you should be more careful about the examination. If you are telling under transfused child chronically, the apex you expect it to be that of a dilated heart. So double confirm it if it is in the fourth intercostal space. Next thing we expect in this particular child, there will be some sort of facial changes. You know, in our case of under transfused thalassaemic child, there are skeletal changes in the face. You see.
Your voice is breaking. I think
There's none, which is a little unlike.
Ma'am, this child was transfused regularly, ma'am. At the first, there was 8 to 6 weeks interval, but now the child received transfusion at 2 to 3 weeks interval. So there was no pictures of facial changes. Or
okay, so such a huge
picture of that baby.
Sorry, ma'am.
If you have a picture of that child with permission, you can show the
No,
picture.
I have not added in the slide, ma'am.
Actually, I have seen the patient. There is no facial dysmorphia. Yeah,
Okay.
yeah.
Okay.
But he should have shown the picture. That is a very important thing. No, you are expecting hemolytic facie who is getting blood transfusion for so long.
Okay, ma'am.
And rightly mentioned by the Dr. Deepshika, some cardiomegaly because of the anemia and regular transfusion, said severe pallor. So if there's a apex which should have been a bit outside, down and out.
Yeah.
Ma'am,
So what are your thoughts here, Dr. Sabir?
ma'am,
At
this
this
is the
point,
picture of the child.
We can't see. Just make it half above. Boro koro আর উপরে যাও উপরে তোলো তোলো. Can't see the face.
Ma'am,
Yes. Okay.
Changes is there.
Yeah. A bit
not
there.
gross, there
A bit-
is
Oh, there is-
prominence there.
Yeah.
There's maxillary prominence.
Mild maximum.
files, there.
Yeah, sure, true. It's not gross. So what are your thoughts, Dr. Sabir, after this, like your history taking and examination? What is your diagnosis, or what further diagnosis? Like, you have to talk about some complications associated with this in the history itself. So any complications you would like to have asked?
Ma'am, I have asked for any history of chest pain or respiratory distress, which will suggest any features of heart failure, or
Yes.
I mean, there is child is around 5 years old, so I will not expect any endocrine changes in this child. But
Okay.
or ma'am,
Acting in a transfusion dependent thalassemia.
or ma'am, any features of hypersplenism, like ma'am, any bleeding manifestation or any recurrent history of infection which will suggest hypersplenism.
Okay. Okay. So good from my side, ma'am. The other expert can ask his questions.
Thank you, Dr. Deepshika, for giving me opportunity. Is there any history of fever, significant fever?
No, sir, there was no history of fever.
Though there may not be significant history of fever, but as it is a hypermetabolic state, there may be some sort of low-grade fever all throughout the day may be there, or some diurnal variation may be there. So sometimes informant may give this type of history. So you have to consider this, whether it is a significant, documented or not, while you are taking history. Okay.
And there are a few questions the chat box. Experts can address those, and the mentors also. Can you see the questions on the chat box and question answers box?
Good evening all.
Good.
Oh,
Yes,
Dr. Rotes, what was the uniqueness of your case? Why did you choose this case to present?
No,
What
this
was
is not
No, no.
for the
special in your
clinical
case?
meeting, so Dr. Shubhendu. This is the learning session. This is a case presentation as a what do you do in the ward, na? It is not that some peculiarity or
Okay,
some.
that's fine.
case there
Okay,
and it is
it's a very
not.
common
What-
case. That's why I was asking.
Yeah, it is a
what-
common case to learn, because it's a common case, they commonly mistake. You see, lots of mistakes are there. So this is our aim to overcome those mistakes, because this is a very common case, one of the commonest cases rather in pediatrics.
It's
So
common. Everyone gets
question,
this case.
two questions from Dr. Madhumita Nandi.
Yes.
One question: if the child is adequately transfused, what was the cause of malnutrition, stunting, wasting both? Why? And nutritional history, I can remember calorie intake is good. There is deficiency of protein, but but protein intake is adequate. Okay. If I am not wrong, can you explain?
It is probably
Hello?
due to decreased calorie intake and or
Okay.
or
Question is disappeared.
huh?
Question has disappeared. No open questions.
First question was, even after the normal regular transfusion, why there's a malnutrition?
Yeah.
it may be due to deficit in nutritional supplementation, or
What was the calorie gap? Amount of calorie gap?
430 around 435 455 kilocalories.
Long duration. Edema was also there. it can be explained by this. Okay. And second question, ma'am.
Second question, I think I forgot even in how come it is gone.
Uh-huh.
Dr. Modubita, you can write the second question again.
Uh-huh.
And there's another question. There are lots of questions are there. Inadequate transmission leading to hypersplenism. Or what is the cause? That is a query. Is it because of the inadequate transmission leading to hypersplenism? Or at what age we expect endocrine changes in child with disease?
There are no features of hypersplenism in this case, ma'am. This child has, it does not fill the criteria of hypersplenism, ma'am, because the requirement of transfusion is not more than 200 or 200 ml per kg per year, or there are no features of cytopenias. Other cytopenias.
Other.
And Dr. Malloy Mondal has answered, it may be due to hypermetabolic state leading to undernutrition or hypercatabolic state, whatever you say.
That is to some extent correct. That is actually demand is increased and at the same time supply is less. That may be there.
Should I continue?
Okay, yes. Is there any question?
Yes, Dr. Moduvita asked what is the exact amount of transfusion baby has received since he was
Yes.
diagnosed a case of hemolytic anemia. What was the interval? What are the volume of blood given? As you said, 2 to 3 weeks interval. Is it still there in 2 to 3 weeks
last
interval?
year, the patient took transfusion at 6 to 8 weeks interval, but now the patient took last 1 year, the patient takes at 2 to 3 weeks interval.
Total transfusion.
You have to be very specific. What is the amount of volume per kg body weight received in a year so that you can decide?
And the patient did not have any thalassemia book, so exact history was not possible from the patient.
Dr. Deepshika, anything? Dr. Shubhendu?
Yeah, actually, the volume needs to be sort of determined. Most of the parents, if you ask specifically, can tell the amount of blood they are getting. And this is important because ma'am is pointing out, do you know what is the indication for splenectomy, Dr. Sabir?
Yes,
What's the indication of splenectomy in case of such a case of, say, thalassemia, a transfusion dependent thalassemia?
ma'am, when there will be more than 200 ml per kg per year blood requirement, or there will be huge splenomegaly which will cause severe left quadrant pain or risk of rupture, or if there is any features of hypersplenism with clinical manifestation of encytopenia.
So yeah, correct. So that's why it's all the more important. Try to ask the parents pointed questions. They are often, when they are being repeatedly transfused, they can often point out the volume. Even if it is not documented, they often know the volume that is being given. Okay.
So there is no question, he can proceed. How will you investigate and manage this patient? What is your final probable diagnosis? All those things just discussed.
From history and clinical examination, this is a case of chronic hemolytic anemia with hepatosplenomegaly, probably thalassemia without any features of heart failure in a child with severe acute malnutrition. Next, I will go for the investigations. First, I will a complete hemogram was done, which shows hemoglobin value of 5 gram per deciliter, MC was 77 femtoliter, and MCH was 24 picogram. Next, PBS shows microcytic hyperchromic RBCs and presence of target cells. Here, this case, retic count was 2%, corrected reticular count was 0.3%. Next, RFT electrolytes was within normal limit. LFT was normal except for total bilirubin 2.9. LDH was 1198. Next, on the iron profile, ferritin was 783 nanogram per ml. Iron was 221 microgram per deciliter, and transferrin saturation was 96%. all serology was negative. On USG whole abdomen, liver was 13.4 centimeter with normal equidistant. Spleen was 19.5 centimeter with presence of gamma antibodies, and 2T was within normal limit. We traced the HPLC report of the parents and the child. HPLC of the patient shows HbA value of 1%, HbA2 value of 3.9%, and HbF of 95%. Father's HPLC showed HbA value of 83%, hemoglobin HbA2 of 5.2%, and HbF was 80.4%, and mother shows HbA2 value of 4.7%. From this HPLC report, we can say that father, mother both are thalassemia trait, and child is thalassemia major, probably beta thalassemia major. So my diagnosis from the is transfusion dependent beta thalassemia major without any significant iron overload. Should I continue?
So, Dr. Sabir, the current classification is a transfusion dependent or a non-transfusion dependent thalassemia, whatever it is, the beta thalassemia or a E-beta thalassemia. When you mention a transfusion dependent beta thalassemia, you need not mention the term major. Okay? The term thalassemia major is now redundant. The current classification is a transfusion dependent thalassemia, TDT versus non-TDT. Okay, so there you need not mention the major component. The other thing, since you mentioned here significant iron overload, you had to mention in the history whether the child was on any chronic medication, especially the iron chelating drugs.
Ma'am, I have mentioned that the patient was not any other medications.
So again, that becomes a little tricky. You have to again double check, because such a long-standing transfusion chronically for so many years without chelation, the ferritin being 783 is very unlikely. Okay.
And moreover, malnutrition is not included in the final diagnosis. You said in the summary there is a SAM. So in final also, all the components should have been
components, correct.
All three will be given. NTD, no chelation, and clinically there's no evidence of iron overload. So how will you know clinically there's a features of iron overload?
Ma'am, the patient was not on any features, did not have any features of heart failure or there are no features of ferritin level was not was below 1000.
Ferritin is the investigation, but clinically, how can you comment? There's a iron overload. Sometimes we see na the slaty color, the skin.
Yes, ma'am.
Yeah, there are lots of questions that will be addressed later. I think experts will take these questions from the audiences given.
Is there any?
Why one question is, I think, when should we start chelation therapy? Can you answer that? When should you start chelation? It's very important.
Chelation therapy should be started when ferritin level is more than 1000 microgram per deciliter. It occurs usually after 10 to 20 transfusions.
How many transfusions?
10 to 20. As per Transfusion International Federation Guidelines 2021.
Yes. And above 2 years. Usually. It should not use below 2 years. So experts can he proceed for investigations?
Yes.
You have shown all the investigation. Do you want to ask any questions on the investigations? Then otherwise we'll go for management part.
Yeah, why did you do the whole iron profile in this particular child? What's the importance or use of doing iron transferrin saturation, TIBC in this particular child?
Ma'am, sometimes there may be iron deficiency anemia. Ma'am, so we can differentiate from the complete iron profile if there are any associated iron deficiency anemia. before.
So that
It
doesn't
is-
happen with a transfusion dependent thalassemia.
Ferritin is, ma'am, is acute reactant, so it may be sometimes elevated due to any other.
No, history is quite obvious. No, in this particular case, history is quite obvious.
Yeah.
And you have already done HB electrophoresis. So
And
diagnosis
moreover,
is your
there is a
comfort.
trait, iron deficiency to be differentiated with the trait, not with the
Yes.
anemia. It is a transfusion anemia.
Yes. So what you're talking about is a non-trans, like a beta thalassemia carrier can coexist with iron deficiency anemia, where you need to diagnose and then you can supplement. But this thing is like this, the whole profile that you have done here is extra. It is not supposed to be done here and is a waste of money in this particular case, where he is supposed to be iron overloaded. They cannot be iron deficient, and in any case, you cannot give any iron supplement to this particular child.
And one thing you have shown the gamma antibodies. What is the importance of that?
And gamma antibody is due to deposition of iron in the spleen, or along with it is usually deposition of calcium with iron in the spleen. It also can occur in other conditions, but it may also be found in thalassemia.
So gamma antibodies it was presented. Can you say there is a iron overload?
Ma'am, we cannot. And there are other causes of gamma antibodies like portal hypertension or sickle cell anemia. So we cannot say that it is. It may
And
be
what
due
is
to,
the serum ferritin level in this particular child?
783.
783. Okay.
Not proportionate with actually transfusion.
Huh?
It is not proportionate with the number of transfusion actually.
Yes, very unlikely.
Unlikely,
Yeah.
okay.
But the serum ferritin have a lots of fallacy also.
And
It can be increased in many conditions, maybe decrease in spite of lots of fallacies are there. Okay. So what else next in which management part we can proceed with the management part. Actually, thalassemia is such a case, the lots of mistakes residents is to do. The lots of queries must be there.
have you done RDW? RDW?
Yes, sir. It was 14.6. 14.6.
What happens in cases of thalassemia RDW? Major
RDW is usually below 13, but it helps to differentiate from the iron deficiency anemia, in which value is usually elevated more than 16 or 17.
I think RDW increase both in thalassemia major as well as iron deficiency.
Any
anemia.
severe anemia can increase the RDW.
RDW.
Should I continue,
next-
ma'am?
Next management part, what did you do?
Ma'am, I have discussed in short about the disease process itself. Should I continue with that, or will I go to the management part directly?
Experts, please comment.
On malnutrition, what investigation you have done? For malnutrition part, have you excluded any infection or other any liver function test or renal function test? Have you done?
Yeah, yes, sir. We have done, sir. RFT was within normal limit, and LFT was there was no significant changes in LFT except for elevated bilirubin, which was 3.1, 2.9, and albumin was 3.1 in this patient. And so malnutrition is due to probably the chronic disease process. There was no history of fever. CRP was not elevated, and
One question is there any specific investigation required for stunting?
So I think if the
Bone
candidates,
age,
you can answer.
you-
Experts can answer.
and bone age, you can determine the bone age also. Or
Yeah,
different.
Start as any other short
Ah.
stature.
Ah.
We him on the growth chart. You have to look at the mid-parental height, just like
Height,
other short stature. You
All
find out if it is familial or not.
Really, this is not a
Really-
stunting. This case is a sham, as he said.
Okay, and as then we go on for the bone age, and in this particular case, like he's sort of young, so for him, like the biochemical parameters like calcium, phosphate, the vitamin D levels, those
Yes.
are more important. The endocrine workup, like this has also been asked earlier. Usually, the endocrine changes tend to set in after sort of 8-9 years, especially when the ferritin is not controlled. In this particular child, as he's saying that the ferritin is well under control, and he's not too old, he's like sort of 4.5 years, so the endocrine component is unlikely to be in play. But if it is like the bone age, etc., is suggestive, we can go in for the endocrine workup, like the growth hormones, the IGF, and so on.
Yes, ma'am. Should I continue with management only?
Okay.
Okay. Okay. Yes.
Management of the thalassemia will be described under following headings. First, we have to do the comparison of the diagnosis, which has been discussed, which will be first done by CBC and PBS, and then we have to differentiate it from the other causes of microcytic anemia. Then we have to do diagnostic tests like HB electrophoresis, HPLC, and confirmatory test should be done by molecular studies to identify the mutation. This is a flowchart showing the steps of investigation. Next, transfusion therapy. This is the spectrum of this thalassemia. It is divided into two parts: non-transfusion dependent thalassemia and transfusion dependent thalassemia. Our patient, beta thalassemia major, belongs to transfusion dependent thalassemia. So, criteria for initiation of transfusion therapy. We should start transfusion therapy when there is confirmation of diagnosis of thalassemia with the laboratory criteria should be hemoglobin level less than 7 gram per deciliter on 2 occasions at 2 weeks apart. We have to rule out the other causes like infections, or if there is any clinical criteria irrespective of hemoglobin level, like any symptomatic anemia, or if there is failure to thrive, or if there is any clinically significant extramedullary hematopoiesis, or if there is any medullary hematopoiesis like pathological fractures or facial changes. This is the various regimen for the transfusion therapy, which is based on pre-transfusion hemoglobin level. We generally follow moderate transfusion, where we take the hemoglobin value of pre-transfusion hemoglobin value of 9.5 to 10.5. This is the transfusion guidelines according to transfusion thalassemia international federation guidelines. Packed red blood cells, leukodepleted by storage filtration, and not older than 2 weeks blood products should be used. Apart from AB and RH grouping, we should do extended red cell antigen typing, like capital C, small c, capital E, small e, and KL antigen. And we should do screening of hepatitis B, hepatitis C, and HIV, preferably by NAT testing. The amount of blood to be transfused is 15 to 20 ml per kg, and at the rate of 5 ml per kg per hour. In case of cardiac failure, we should transfuse at the rate of 7 to 10 ml per kg, not more than the rate of 2 ml per kg per hour. Next, we come to the chelation therapy. This is a diagram showing the mechanism of iron overload, which is mainly due to non-transference bounded iron, which leads to reactive oxygen species formation, which may causes damages to the heart, liver, pancreas, and other pituitary organs like pituitary and gonads. Usually, we see the effects of iron overload after the age of 10 years in the form of endocrine changes. There are many methods of estimation of iron overload, like serum ferritin level or liver iron concentration by biopsy, or any non-invasive squid technique, or myocardial iron estimation by T2 MRI. We should start iron chelation when the serum ferritin level exceeds more than 1000 microgram per liter, which is usually reached after 10 to 20 transfusions. We commonly, there are chelation agents available for chelation therapy. One is parenteral and two are oral. Among the parenteral, there is deferoxamine, which is given by slow subcutaneous or intravenous infusion. It has a short half-life of 20 to 30 minutes, so we give a continuous infusion by 8 to 12 hours a day and 5 days a week. the dose is 30 to 40 mg per kg per day. It can cause severe local reactions, ototoxicity, retinal toxicity. To avoid local reaction, we usually give it with lignocaine or imlacrim, and we have to monitor yearly auditory and ophthalmic changes. Another agent available is difeprone. It is a oral agent given in 3 divided doses. Total dose is 75 to 100 mg per kg per day. It may cause arthralgia and acrocytosis, so we have to check for CBC initially every 2 weeks. Most commonly used agents in our country is Desferra. It is available in dispersible tablet form or pen-coated tablet. It has a half-life of 12 to 16 hours, so it can be given as once daily dosing. If dispersible tablet, it is given at a dose of 20 to 40 mg per kg per day. For pen-coated tablet, the dose is 30%, which is 40 to 28 mg per kg per day. It may cause transaminitis, azotemia, or microalbuminuria. So we have to monitor 3 monthly serum creatinine value, serum transaminase, and urine REME. There are mainly five methods of the chelation therapy. So we commonly follow these 3 prevention therapy to maintain a safe level of body iron at all times by balancing iron intake from blood transfusion with iron excretion by chelation. We give rescue therapy to remove excess iron stored in the body, or emergency therapy in case of iron-induced heart failure to urgently intensify iron chelation. There may be endocrine problems later in the later half of life, usually after 10 years. Following endocrine problems can be seen like delayed puberty or hypogonadotropic hypogonadism, subclinical hypothyroidism, impaired glucose tolerance and insulin-dependent diabetes mellitus, hyperparathyroidism, and subclinical adrenal insufficiency. We have to investigate for endocrine problems like by following investigation: serum TSH and FT4, serum calcium, phosphate and ALP, serum IGF-1, MRI for hypothalamic pituitary region, serum LH, FSH, sex steroid, and oral glucose tolerance test. Next, modulated treatment is splenectomy. We generally do splenectomy if packed rectal transfusion exceeding 200 ml per kg per year, or if there is massive splenomegaly with left upper quadrant pain or risk of rupture, or if there is any hyperspasm causing clinical problems, cytopenias. Splenectomy is contraindicated before 5 years of age. We have to give pneumococcal, Haemophilus influenzae, and meningococcal vaccine 4 weeks before surgery. We generally give for immunococcal vaccination. We give PPSP 23 4 to 6 weeks before the splenectomy. But before that 8 weeks before, we have to give PCV 13 vaccine. If child is immunized according to NIS, then we don't have to give pneumococcal vaccine if it is within 5 years of 5 years. For meningococcal vaccine, we give main ACY vaccine 4 to 6 weeks before surgery, 2 doses, and ACWI. And for hemophilus, we give HIV vaccine 4 to 6 weeks before surgery. If emergency, we can give this vaccine after 2 weeks after splenectomy. After splenectomy, there is a risk of overwhelming post-streptococcal infection. So we have to give oral penicillin prophylaxis for 5 years. We have to treat any febrile episode at earliest possible, and we have to give low-dose aspirin prophylaxis in these patients, as there is risk of thrombocytosis. We have to monitor follow the following parameters. In each visit, we have to do complete blood count, anthropometry on growth charts, and liver and spleen size. Every 3 months, we have to do serum ferritin, serum creatinine, serum transaminase, and urine for microalbuminuria. Yearly, we have to do annual blood transfusion requirement, HbA1c, anti-histamine, ICDC, and auditory ophthalmic evaluation for desferrexamine. Yearly, after 10 years, we have to do endocrine screening for thyroid, parathyroid, diabetes. We have to do cardiac screening with 2D echo. We have to do bone mineral density with DEXA scan. Or we have to do sexual development with Tanner staging. If Tanner staging is not according to age, we have to do further investigation like FSH, LH, and testosterone. There are some newer modalities for thalassemia treatment. One of the is hematopoietic transplantation. It is a curative mode of therapy. It should be offered at an early age, before 7 years, before the complications due to iron overload have developed. It has best outcome if done is less than 7 years of HLA identical sibling donor. It has worse outcome if associated with hepatomegaly, liver fibrosis, or poor adhesion to chelation therapy. Another new modality for the thalassemia is gene therapy. Gene therapy provides cure for thalassemia through the manipulation of the genome of the hematopoietic stem cells, thus compensating for the inadequate or faulty function of mutated genes. There are two mechanisms for this: gene addition or gene editing. For gene addition, by using a viral vector, we do insertion of a healthy copy of therapeutic gene into the cells. And by gene activating, we do a directed mutation that repairs the defect in situ, or it induces a disease modifying defect like deactivation of HPF synthesis using site-specific nucleases. There are some novel therapies available for thalassemia. Some act by targeting ineffective erythropoiesis, like JAK2 inhibitor ruxolitinib, AC011 for sotorasib, and AC550 luspatercept. Some we can induce cell hemoglobin synthesis by hydroxyurea thalidomide. Nutritional supplementation, consumption of balanced diet consisting of dairy products, cereals, and fruit and vegetables should be done. We have to avoid intake of iron-rich foods like green leafy vegetables like spinach, broccoli, cabbage, or legumes, dates, jaggery, etc. We have to avoid cooking in iron cooker. We have to drink tea or coffee with meals, as tannin can impair with iron absorption. And supplements with vitamin D, calcium, folic acid, and zinc should be given. This is the diagram showing the genetic of the thalassemia. So in this case, we see that each child has 25% chance of inheriting to normal gene, and 0.3% chance of the child is being thalassemia trait, and 25% chance that the child will be a thalassemia major. So for prevention of thalassemia, we have to do following things: community education and awareness programs to remove any myths regarding transmission or disease stigma. We have to install a sustainable and cost-effective career screening programs at school level, or any genetic counseling, post-screening genetic counseling, or establishment of services like community level premarital and preconception screening. And we have to do the screening of the extended family of the carriers and patients. So take-up points from the management: institution of transmission regime soon after diagnosis, serial ferritin monitoring to look for iron overload, early initiation of chelation therapy and monitoring for compliance, and counseling of the parents and expression of the risks of future occurrence, and newer modalities like HSCT and gene therapy for complete cure. Thank you.
Some comments from the mentors, and then I will like to have comments from the experts also. So mentors, please, you want to make some comments.
There is one question. What about fetal diagnosis of thalassemia?
Yeah, prevention part should have been highlighted a bit more, because that's the more important part nowadays. Diagnosis is not that difficult, but the prevention is most important part. So can you say something, Dr. Brotesh, Dr. Shubhendu?
Prevention, ma'am, for our prenatal diagnosis, we can do chorionic villi sampling or amniocentesis.
Whom?
To
To
the
whom? What is the program, the control program is running in our country? Thalassemia control program. Can you tell me, can you highlight? Each and every pregnancy will go for CVS?
No, ma'am. Why there is a family history of any
So
thalassemia
first
disease?
pregnant lady will come in the ANC, will do the testing.
Next of testing.
Not disturbed in,
Desktop is not.
It is included in the NHM guidelines. But
Yes.
it is not done.
You
Dr.
just
Deepshika,
Yes, ma'am.
can you highlight that program is going on running in the country?
So first and foremost is like any antenatal mother who is coming in should be offered, counseled and offered HPLC testing to look for any hidden carriers that are in the community. If she comes out to be positive, very important to test the partner also with HPLC. And if both partners turn out to be carriers, then comes the question of antenatal diagnosis in the fetus that you were suggesting. And in this case also, we prefer to do amniocentesis, which is safer as compared to CVS. And it is important that it is done within the first trimester, so that you can, if you have a diagnosis of supposedly major thalassemia beta beta thalassemia major or any other transfusion dependent thalassemia in the fetus, you can offer abortion choice to the parents. Because if it crosses the say 16 to 20 week mark, then even if you diagnose, the mother will not be able to abort that baby. So that's what is important.
Yeah, and the latest
and-
guideline is everyone should know their status, and each and every individual. That is the 2022 guideline. You have to know your own status, like in HIV we say. Similarly, in thalassemia and sickle cell disease, everyone should have known their own status.
Should
And,
advise another question, should advise a balanced diet including vegetables, fruits and all. It is the transfusion that mainly contribute to iron overload.
Yeah, you cannot curtail the diet, no? So, it is said that citrus fruits or vitamin C rich food should not be combined with the iron containing foods. Okay, they should be separated. Otherwise, the vitamin C will enhance the absorption of iron which is there in the gut. And there is it is said you can have a cup of tea that contains tannic acid that especially hampers the absorption of iron from the gut. So, any comments from the experts? Any more comments? So, otherwise,
I just want to ask one question.
Dr. Shapul, please.
Madam, you permit. I just want to ask one question. So you have shown the transfusion amount is 15 to 20 ml of the PRBC or whole blood.
PRBC.
15 to 20 ml. And in severe heart failure, you have written 7 to 10 ml. And we know in severe anemia, if you give much more overload, it causes the heart failure. And that's why we give 3 to 5 ml per kg of body weight. So I just want to know from the expert, that Deepshika is there, what is your take? Should we give 7 to 10 ml or 3 to 5 ml?
Sir, I already answered that in the chat box also. You're absolutely correct. Severe hemoglobin, usually we take a cutoff of say 5. If it is below 5, we start slow with a small volume, around 5 ml per kg. In this particular case, also you can use furosemide as a diuretic midway or end of transfusion. Carefully monitor the child. But also, having said that, we have to top up the child the next day with another unit of say again now 10 to 15 ml per kg as per tolerance. So that finally the pre-transfusion hemoglobin sort of goes up to the 10 or like 9 to 10. We keep a cutoff of 8 because it's a resource limited setting. So at least the hemoglobin should go up above 8 to 9 before discharge.
So our target should be 9.5 and above.
By textbook,
And
it's 9.5 to 10.5. For practical purposes, for our patient, this is not for the students. For our resource limited settings, we are advising above 8 gram per DL pre-transfusion.
Or you can give different aliquots in a weekly basis. That is also said. And
that doesn't work, ma'am. At a time,
yeah,
we
Dr.
want
Deepshika, my question is, how many transfusion consecutively for how many days you can give? Because we have seen if you give the consecutively 3 days transfusion, we have seen few cases, quite a lot cases of press after giving a massive transfusion. So we don't give what we do. We do the one first day, second day, we give the gap of 1 day and then 4th day, not a consecutive of 3 days. What's your take on what's your advice as an expert?
Usually, ma'am, it's a fresh blood. By 2 days, 2 consecutive transfusion, we usually reach our target of 8. But definitely, if a larger volume is needed, it's prudent to give a break, ma'am. A day break, as you are suggesting, it is possible. And also for practical purposes, ma'am, it's easier for the family also to come back like at an interval of 1 week or so. So that also can be done.
Yeah. At a state consecutively 3-4 days, it can lead to some complications.
Yeah, correct, ma'am. Dr.
Shubhendu is there? I can't see.
Yes, I'm there.
Oh, you do?
I want to just know from Deepshika that what is the probability or availability of stem cell transplantation and gene therapy in India? How come? What are the statistics? How come they are recovering?
Yes, good.
Gene therapy is not available currently at India, but stem cell transplantation readily available, a very good choice if the family is affording. It should be advocated to all our patients. So even in Kolkata, it is being done. Tata
That's
Even in
fine.
Medical College also, Calcutta Medical College also.
Correct. Even like we have it at, and now the children are being taken up also at NRS and Medical College, Kolkata. So that's
That's
very,
fine.
and like if the success rates are very good, if the child is in like if you transfuse the child well, keep the ferritin levels good, the liver is in good condition, the chances of success of transplant is as high as 80 to 90%. And the child is cured completely of their disease. So we should advocate transplant if the parents are, of course, affording. We should advocate transplant to all patients diagnosed with transfusion-dependent thalassemia.
That's good.
Okay. So if there's no more comments or questions, we can proceed to second case. Experts, please. So thank you, Dr. Savi, Dr. Brutesh, for your nice, there are some lots of lacunae, which is a learning process. You learn and you will improve yourself. And thalassemia is a big chapter. And the aim of this presentation of cases are to learn. And as you appear in the exam and you face the questions, and that is a one sort of rehearsals, because you are getting questions from all the experts, all the seniors who are going to be examined, all of you. So it is an opportunity to learn from your experts. That's why this program is going on. So thank you, Dr. Brutesh and Dr. Sabir.
Thank you.
Now I'll
Thank you.
invite this.
Ma'am, just one comment, ma'am.
Yes.
For especially the resident, Dr. Savi, presentation was very good. You have read it up very well. I just want to emphasize in the word, please do practice palpation of the liver and spleen. Okay, you should be able to demonstrate that. That is where, like at the exams, what we are seeing that even the theory part you are doing okay, but many residents are failing at demonstrating just the liver palpation and the palpation of the spleen. So you should be very confident in that, and I think your senior resident can help you with that. Okay.
Yes.
Thank you, ma'am.
Thank you, ma'am.
Thank you, Deepshika. You have told the 100% correct. They are very good in theory, but they're very shaky in practice. So that should be practiced daily.
One question from me, that is any, Sabir, can you tell me what are the most common 5 genes you search for in while you are doing genetic analysis and what is common in our country? You should remember, okay? Only 5 genes is there, more than 90%.
IDS 1-to-1 relation, IDS 1-to-6, and
Okay, just okay. You just read it. That is 619 BP deletion, IVS 1-to-5 GC, and IVS 1-to-1 GT, and FS 8/9 and FS 41/40. Okay, just.
Now, I think I will request the second, Dr. Shubhendu. Please introduce our presenter.
Yes, Dr. Arpan Satpathy will now unfold a mysterious case of anemia. The case was being admitted at Bardhaman Medical College in the month of May, and Dr. Satpathy will go ahead to explore the case. Dr. Satpathy, you may now proceed.
Sir. Am I audible?
Yes, you're audible. Your slide is also visible.
Okay. Good evening, everyone. Shubho Sandhya. Myself, Dr. Arpan Satpathy, the first year PGT, Bardhaman Medical College, and the tale I will tell today is about a mysterious case of anemia. Mr. X, a 6-year-old male from Bhatar, Purba Bardhaman, admitted in our medical college, Bardhaman, on 3rd May 2023, and I examined the patient on the same day. Here the informant is his mother, who is reliable and studied up to class 10, and patient himself. He admitted with the chief complaint of easy fatigability for last 2 months, fever with malaise for 2 weeks, increasing pallor for 1 week, and palpitation and shortness of breath for last 2 days. Now, the history of present illness. The child was apparently healthy 2 months back when he started experiencing easy fatigability, which was insidious in onset and gradually progressive. Previously, the child was able to go to school and playground, which was approximately 2 kilometers from his house without any difficulty. But now he is facing problem in doing daily activities like taking bath, going upstairs, or going to nearby shop. The child also developed low-grade fever, which was undocumented, associated with malaise and joint pain 2 weeks ago, which was relieved on taking medicines. No history of any rash, chill or rigor, or any bleeding spot in skin. The mother has also noticed that the child has become pale since 1 week and associated with swelling of hand and foot and also facial puffiness. The child also experiencing shortness of breath and palpitations for last 2 days, even while doing daily activities like bathing or going upstairs. Now, important negative history. There is no history of any chest pain, transient loss of consciousness, or decreased urine output. No history of hematemesis, melena, hematochezia, epistaxis, hematuria, or bleeding elsewhere. No history of any blood transfusion or jaundice in past. No history of evening rise of temperature, chronic cough, or chronic diarrhea. No history of weight loss or bone pain. Also, no history of any exposure to drugs and radiation. Now, past history. There is no similar complaints in past. No history of previous hospitalization or surgery. Only positive things is the passage of worm in stool. Now, in birth history, the antenatal history, natal history, and postnatal history all are uneventful. In developmental history, a child developmental milestone has been achieved regularly and is appropriate for his age. In immunization history, the child is immunized as per the NIS guideline. In family history, the family composed of 4 members, no consanguineous marriage, no similar history, no similar disease, and also there is no history of any congenital anomalies. Now, personal history. The child takes a mixed diet, which is predominantly vegetarian. Total calorie intake is 1300 kilocalorie per day, and protein intake is 16 grams per day, and appetite bile bladder is normal. History of pica present. In socioeconomic history, the child belongs to the lower middle class according to modified Kupusami scale. In environmental history, the child lives in a kacha house without overcrowding and ventilation, though hand hygiene and toilet practice is not satisfactory. Now, clinical examination. First, general survey. We find the child is alert, conscious, and oriented. Pallor is moderate to severe. Peripheral edema present. Icterus cyanosis clubbing not present. The pulse 126 per minute, regular but hypervolemic, though no radioradial radiofemoral delay. The blood pressure, respiratory rate, temperature is normal. Lymph nodes not enlarged. palpable and neck bend not enlarged. No bony tenderness found. Now, on an anthropometry, the height is found 110 centimeters, which is around 25 percentile, and weight is 16 kg, which is around 10 percentile. Now go to the systemic examination. First, in gastrointestinal and hepatobiliary system examination, there is no significant findings on inspection, palpation, percussion, or auscultation. There is no hepatosplenomegaly. On cardiovascular systems, S1, S2 audible, and systolic grade 2 murmur on pulmonary area, most likely be a hemic murmur. In respiratory system also, no significant abnormality detected, bilateral vesicular based sound, and along with no adventitious or added sound. In central nervous system also, patient is oriented time place person, no cranial nerve deformity, along with the reflex, tone, power, or other functions are normal. So, in summary, a 6-year male child who is a second born to a non-consanguineous married couple present with progressive easy fatigability since 2 months, which was insidious in onset and gradually progressive, and now it present even on doing daily activities. There is also increasing pallor since 1 week and palpitation and breathlessness since 2 days after an undocumented fever 2 weeks ago. The child consumes a predominantly vegetarian diet, which is deficient in calorie, protein, and iron. He is immunized up to date as per the national schedule and with normal developmental milestone, and belongs to lower middle class according to modified Kupusamy scale. On general examination, pallor is moderate to severe, peripheral edema present, pulse rate is 126 per minute, hypervolemic, no icterus, clubbing, lymph nodes, or bony tenderness present. On systemic examination, CNS, respiratory, GI system are normal limit, no hepatosplenomegaly. On CVS examination, S1, S2 audible with a grade 2 murmur present on pulmonary area. Should I proceed?
Yes.
So my provisional diagnosis, it's a case of neurocellular anemia, or iron deficiency anemia.
Now, what point before proceeding it?
Before proceeding, Dr. Tadok and Dr. Dipshi, I would like to ask you people say a few comments on the examination part also. History taking and examination, anything is left and not.
Okay, okay.
Then he will go for the further. So it will be learning process.
See, is there any history of pica?
Yes.
Summary?
Yes, sir.
Well, you should mention summary also.
Yes, sir. History of pica present, and also history of passage of worm of stool.
Worm, which type of worm? Actually, all worm.
That's actually the patient mother not able to
Able to.
আমি জিজ্ঞেস করলাম যে বাচ্চা দিয়ে কৃমি বেরোয় কিনা, বলেছিল হ্যাঁ বেরোয়, মানে বেরোতে।
Blood loss history is there?
No, there is no. There is a no hematemesis, melena, hemoptysis, epistaxis, or any bleeding for anyone.
What is the age? 2 years?
6 years. 6 years.
Sorry. Okay. Sorry.
For this particular kid, I would also like a bit more elaboration on the dietary history. Especially, you need to mention about the cow milk, if there's any history of excess intake or so on.
Actually, ma'am, is it predominantly taking the milk and the cereals? ভাত আর ওই দুধ ভাতই বেশি খায়, ও যখন যে সকালবেলা উঠেও
So
খায়।
you need to
Which
highlight.
milk? Which milk?
Yes,
cow milk,
that's
cow
also.
milk.
Yeah.
Is there any relation, madam? What?
Actually, cow milk, there is a deficient in iron. In human also, the iron content is less, but the iron is in plus form, so it's more absorbable. So cow milk, there is a chance of iron deficiency. Along with that, there is a cow milk, there is a chance of allergy. So in that case also, cow milk is related to the iron deficiency anemia.
How is it related? Like, what is the exact term called? The allergy to cow milk, and how does it cause iron deficiency anemia exactly?
Kaumil allergy is 6 years. Very unlikely.
Unlike
Actually, it is less than 1.5 years.
it is usually below up to 3 years, maybe maximum up to 3 years.
জানি এমনি কাউ মিল্ক ইজ ডেফিসিয়েন্ট ইন আয়রন, সেটাও একটা কারণ হতে পারে যে জন্য আয়রন।
CMPA, actually it is called CMPA, not
CMPA.
আচ্ছা
And any other, like somebody asked here, like what particular milk is he taking? Is there any other animal milk associated with some particular nutritional anemia?
Yes, very good question.
goat milk, vitamin B12 deficiency.
Okay. So
Folate.
coming to that, what are the
Folate,
what
sorry.
finding would you find in general survey to suggest that it is a megaloblastic anemia, sort of B12 or folate deficiency? Any finding on the general survey or your general physical examination, which you have not mentioned actually?
Regional survey. Regional survey. We should mention hands, food.
There is no nail changes there is or megaloblastic anemia.
Any pigmentation.
So hyperpigmented knuckles are sort of typical with megaloblastic anemia. And so what are the nail changes associated with iron deficiency anemia that you were mentioning?
Actually, maybe there is a platinikia or the koilonychia.
What are they? What is koilonychia?
The koilonychia is a curvy and a platinikia is the flat nails.
Okay.
In
Do you know-
iron
But there is
deficiency,
not present in our case.
Do you know of
Here may be lusterless or brittle in iron deficiency. That is
any
also not.
nail syndrome associated with iron deficiency anemia? One of the components of this syndrome is like the koilonychia. Do you know of any named syndrome? Have you heard of Plumer-Vinson syndrome? So that can be like iron deficiency anemia, esophageal webs, and koilonychia. So they can be a triad of that, and it's like sort of a viva question basically. So again, your history, you seem to suggest that the child is in CHF. Is he in cardiac failure because of the severe pallor?
History of it.
Do you?
Child is in impending cardiac failure, not in cardiac failure, because in cardiac, in it's a cardiac failure, we can get a basal crepes or the liver may be enlarged or palpable.
Okay.
Actually, it is a chronic anemia, so I think the heart is tolerating well the low hemoglobin pallor.
Is there pigmentation, regarding pigmentation, any other significance regarding this morphology along with the pigmentation?
স্যার যদি লেট যদি ডিপোজিশন হয় সেক্ষেত্রে একটা লাইনে মিক্স লাইন পাওয়া যায় অনেক সময়।
Some hereditary disease present in the later age. That is Fanconi's anemia. That is Fanconi's anemia may be also associated with pigmentation or skeletal deformity.
Microcephaly.
And also nail dystrophy may be keratosis.
yeah, this is a dictum, no? If there, from the history, what did you think? It is a deficiency anemia or hemolytic anemia, or what? Is there any suggestive type of anemia we could get from your history?
Nutritional deficiency anemia.
Huh?
Ma'am, deficiency anemia, not hemolytic anemia.
No.
Okay.
If
You
you
think
go
of
through the
deficiency of bone marrow suppression.
Ma'am, no, not bone marrow suppression at the present moment, because in bone marrow suppression we get the sometimes we get the any bleeding spot due to the decreased platelet count or more chance of infections due to if there is that WBC count is less.
So Dr. Arpan, there's a entity called pure red cell aplasia.
Yes, ma'am.
Okay. So but it can be only the RBC series in the bone marrow which is suppressed. So ma'am is absolutely correct. The close differential in this case will be a bone marrow suppression, a bone marrow failure syndrome, like a pure red cell aplasia.
Yes,
So you have to keep that in differential.
yes, ma'am. Actually, this is a rare case, so we kept in rarely because I think the most common cause we kept in the provisional.
Okay,
That's good, but you have to discuss all the differentials. You cannot
Yes,
be
yes.
one tracked.
Yes, ma'am.
let's proceed.
Was it no?
Is there any history of any evidence of glossitis or
One thing
no.
I'd like to say, Dr.
Okay.
Tarak, on the pulse we
Okay.
say high volume, not hypervolumic.
I will.
High volume pulse. You always follow the standard clinical method book.
Achha. High one. Achha, high.
Okay, proceed.
So my provisional diagnosis is a nutritional iron deficiency anemia. The points in favor, it is the most common type of anemia, not only in India but also in the world. The diet is deficient in iron, the history of pica present, and there is no hepatosplenomegaly. But the point against is the sudden exacerbation. The differential diagnosis, it may be a aplastic anemia or nutritional megaloblastic anemia. The chronic hemolytic anemia like the thalassemia intermediate or acute leukemia, maybe anemia due to chronic blood loss. Or the rare possibilities are like chronic anemia due to chronic disease, chronic malaria, autoimmune hemolytic anemias, or any enzyme defects.
One minute. On your DD, just go back to a DD. Yeah, how come aplastic anemia and chronic hemolytic anemia, that too also intermediates will be coming together? Because the chronic hemolytic anemia, DD, you kept the aplastic anemia, nutritional, okay, acute leukemia means pre-leukemic state and all. But chronic hemolytic anemia, that too also intermediate variety is the entirely different. No, you will have a hepatosplenomegaly, late presentation, chronic.
Small hepatosplenomegaly we can miss in clinical examination.
Did you get the hepatosplenomegaly?
No, on clinical examination.
So, did you get the history of jaundice?
No, no jaundice.
No, so clinically there are no features suggestive of first hemolysis, second chronicity. So I don't think it will be in the DD.
Only two months history. Only 2 months history, yes.
আমি একটা বলছিলাম যে যদি ফার্স্ট টাইম যদি মানে থ্যালাসেমিয়া ইন্টারমিডিয়েট হতে হিমোগ্লোবিন কম হয় না, সেক্ষেত্রে অনেক সময় দেখি যে লিভার ইনক্রিজ ওয়ার্ক করে একটু 2 to 3 ফোল্ডস, অনেক সময় ম্যাম ইন্টারেস্টটা বুঝতে পারা যায় না যেমন প্রথম দিকে, ওই জন্য রেখেছিলাম।
Maybe including the later part. Okay.
আচ্ছা, proceed করব। So we go for our investigation plan. For day 1, we go for complete blood count, peripheral blood smear, reticulocyte count, high performance lipid chromatography, liver function test, urea creatinine, and iron profile. So the report for day 1, complete blood count, we get the hemoglobin is 3 gram and total count is normal 6,200, platelet is 1.88 lakhs, and malaria MP is not found. In the peripheral blood smear, we found the microcytic hypochromic nature of RBC along with anisopoikilocytosis, so which favors our diagnosis of iron deficiency. Along with this, there are some teardrops of target cell present, so maybe in the case of some thalassemia also, and where there is no blast cell presence on peripheral smear. So from this differential diagnosis, now we can definitely rule out the nutritional megaloblastic anemia and also the malaria part. And there is this confirmatory we can eliminate, but there is indirect evidence against the aplastic anemia and acute leukemia also, though we need further tests to confirm it. Now the day 1 reports renal function test, we see the urea creatinine report in normal level. Along with that, the liver function test is bilirubin is 1 and liver enzymes also normal. So the hemolytic ones are, there's indirect evidence against the hemolytic ones, because you know in hemolytic anemia there is an increase in the indirect bilirubin, unconjugated bilirubin levels. So by indirectly we can rule out the hemolytic ones along with the anemia due to chronic diseases. Now in the day 1, the 1 unit of the PRBC transfuse along with other symptomatic management given. Now day 2, we go for ultrasonography whole abdomen, which again show no hepatosplenomegaly, and no gallstone, which is favorable for hemolytic cases, and along with there is no significant renal pathology found.
Dr. Malay Mandal has asked what is the RDW?
RDW ম্যাডাম আমরা পাঠিয়েছিলাম RDW এটা কিন্তু এটা আসেনি রিপোর্টটা ম্যাডাম আসেনি
Okay, ঠিক আছে।
and thyroid function test is also seen also within normal limit. So from this we can now the anemia due to chronic disease has the indirect evidence against it. Now in day 3 the 1 unit again we will transfuse 1 unit of PRBC and also the blood for occult stool for occult blood and ovum parasite and cyst sent. We saw there is no occult blood. Along with we do the HPLC report, okay, which is show the normal pattern. So from this differential diagnosis, now we can definitely rule out the thalassemia and anemia due to chronic blood loss. So by the end of day 3, we are happy because most of our differential diagnoses are either ruled out or there is indirect evidence against it, and the peripheral blood smear that is showing the hypochromic microcytic anemia, which favors our provisional diagnosis. Now, day 4, we get the iron profile reports. We see the serum iron in 178 in the normal range. Total iron binding capacity is also the normal range, and ferritin is 180 is also in the normal range. So now we are not happy because our provisional diagnosis is in danger now. So what we do in day 5, we revisit the case and plan for further investigation. We plan for bone marrow examination and repeat our complete blood count. We also do the PTINA, which is normal, HIV, which is non-reactive, and hepatitis B surface antigen also negative. Now this is the day 6, the CBC report. We see the hemoglobin is 9.7 now. The total count, WBC count, and the platelet is normal as before. The patient is hemodynamically stable now, so we can go for bone marrow aspiration cytology. And here the bone marrow slide, here you can see the erythroid cells. These are the erythroid cells which are less in the slide. The larger one is the proerythroblast, and the small one here is the intermediate normoblast. And in that cell, we can see the large proerythroblast, which has the vacuolated cytoplasms along with some pseudopods. You can see also here also the vacuolated cytoplasms. So most likely it's some infected proerythroblast. And in that slide, we can see the erythroid cell clusters, and so here the cells should be less than 5% for diagnosis of. Now, day 7, we get the bone marrow aspiration cytology report. Again, when the RBC morphology, you see the microcytic hypochromic nature with severe anisocytosis in myelopoiesis and megakaryocytosis is normal. There is no abnormal cell. Only problem in the erythropoiesis, which is slightly reduced, and along with the nucleocytoplasmic asynchrony is there. So now we can definitely rule out any leukemia. Along with that, it points towards isolated erythroid aplasia. So day 8, we go for the causes or pure red cell aplasia. It may be a case of transient erythroblastopenia of childhood, but as we know, the most common age is from 6 months to 3 years in 90% of the cases. So this is less likely. It may be some viral infection, as we already saw in the bone marrow slide also, like pyrovirus, cytomegalovirus, Epstein-Barr virus, and other viruses also. Or maybe some offending drugs like chloramphenicol, valproate, and many more drugs. So we plan to go for RT-PCR for parvo B19 virus DNA in bone marrow sample. Now, this is the report of day 10. We saw that the parvovirus B19 is detected in high amount in the bone marrow specimen. So, our final diagnosis is the parvovirus induced pure red cell aplasia. But there's a point in favor. First, so there's a bone marrow biopsy report which shows that the isolated erythroid aplasia. Along with that, the RT-PCR reports also is showing that the parvo B19 in bone marrow sample is a definite proof, obviously. But there is also some point against it. First, the long-standing history of 2 months, which may not be there in the case of parvovirus. as it is self-limiting, often within 2 weeks, along with the microcytic hypochromic anemia from the day 1 report also, and the day 10 also the microcytic hypochromic nature in the bone marrow. So we change our final diagnosis a little bit. So it is a parvovirus induced pure red cell aplasia, probably in a pre-existing iron deficiency anemia patient. Now, this is the treatment when already told that the 2 unit of PRBC transfusion, along with the supportive treatment like moist oxygen, then injection furosemide in the day 1, and tablet albendazole, and syrup iron folic acid. And what treatment could be given, as we know that no specific antiviral therapy against the parvo-V19, and there is questionable use of steroid and IVIG in severe forms and immunoglobulin patients. So this is the discharge certificate of the patient, where we discharge the patient with iron syrup and albendazole along with dietary modification, and asked to follow up after 2 weeks with complete blood count report. And here we see the complete blood count report after 2 weeks. Now we are happy to see the hemoglobin in 2-digit number now. And these are some relevant publications regarding the parvovirus induced pure red cell aplasia in the different reputed journals. So this is the take-home message. So if you diagnose a rare disease, you are rarely correct. At the same time, rare diseases are rare because we rarely think about it. Firstly, I like to thank the West Bengal Academy of Pediatricians for giving me the opportunity to present this case in this prestigious platform. I would like to thank my mentor, Dr. Subhendu Dey, and expert Professor Dr. Bose for their constant motivation and support. Department of Pediatric, Bardhaman Medical College for the infrastructural facility, and my co-PGT, Dr. Molloy, and the other unit members, Adil and intern Nirojan Preksa, for their help. And extended thanks goes to the collaborating department, radiology and pathology, for their help in diagnosis and providing me the slides. Thank you for your patience here.
Okay, thank you. Very nice case, nicely worked up. And now I invite the questions from the experts.
In any cases of anemia, you have to see 3 things, that is MCV, RDW, and retic count. In your case, 2 vital investigation you could not found, that is retic count and RDW. It should be brought. You have to take initiative to get the reports. Otherwise, it will be very difficult to proceed for any diagnosis of anemia. And regarding in that cases, initially is a hypochromic microcytic anemia. So what are the other degrees of hypochromic microcytic anemia you search for?
You can stop sharing.
এটাতে আমরা পাঠিয়েছিলাম, কিন্তু রিএজেন্ট অ্যাভেলেবেল ছিল না ওই মুহূর্তে আমাদের হসপিটালে, ওই জন্য আমরা করতে পারিনি। তারপর তো ম্যাম খারাপ হিমোগ্লোবিন খুব কম ছিল এবং ইম্পেন্ডিং হার্ট ফেলিওর ছিল বলে আমরা ওই রাত 2টোর সময় অ্যাডমিট হয়েছে, আমরা মানে ভোরবেলার মধ্যে ওকে ব্লাড দিয়ে ফেলেছি। ওই জন্য স্যার আমরা ওটা করতে পারিনি, মানে তার ব্লাড দেওয়ার পরে আর পিভিএস মানে আলাদা করে রেটিনোসাইট কাউন্ট আর করা যায়নি। ওইটা একটা আমাদের প্রবলেম হয়েছে।
Okay, and you have to understand your difficulties of getting report, and at the same time you have to be careful enough to take the initiatives to initiate vitals report, get your hand. One thing. And what are the other hypochromic microcytic anemia for which investigation you have done apart from iron deficiency?
Dr. Arpan, you just stop sharing.
Stop.
So we can discuss the next thing. Dr. Deepshika and Dr. Taru, continue.
হাইপোক্রোমিক অ্যানিমিয়া একটা কারণ তো থ্যালাসেমিয়া হতে পারে, আমরা যার জন্য এইচপিএলসি করেছি। এছাড়া ক্রনিক লেড পয়জনিং একটা কারণ।
Click on stop sharing.
Stop sharing.
Stop.
Okay. Thalassemia you have ruled out. Then
anemia due to hypokalemiaর জন্য আর স্যার lead poisoning হতে পারে বা কপার ডেফিসিয়েন্সি একটা কারণ হতে পারে, যেগুলো খুব রেয়ার কজ, ওইগুলো আমরা দেখা হয়নি। প্লাস যেহেতু বাচ্চাটা হিস্ট্রি আছে পাইকার, তো ওই জন্য ও মাটি টাটি খায়, তো সেক্ষেত্রে একটা মানে প্লাম্বিজমে একটা চান্স তো থাকেই।
Okay, you should not consider in that cases because other causes are obvious. Okay, but you should always keep in mind these should be always kept in mind. Rare cause and another sideroblastic anemia and bone marrow examination. You have not got any sideroblast.
Dr. Deepshika?
First of all, Dr. Arpan, very nicely presented, lots of twists and turns, a very interesting case.
Thank you, madam.
My comment on the bone marrow actually, how do you like confirm the diagnosis of iron deficiency anemia? What would be the finding on bone marrow? Especially because you are still keeping a diagnosis of pre-existing iron deficiency anemia in this particular patient.
Ma'am, in
So
bone marrow, when they do the bone marrow, they also do a peripheral blood smear. May I show the slide? And in the slide, they are written that
I'm asking you, what is the finding on the bone marrow for to clinch a diagnosis of iron deficiency anemia?
actually, ma'am,
In other words, what are the clue? What are the methods of iron estimation in bone marrow?
what is the confirmatory test iron deficiency? আমরা বোন ম্যারোতে আয়রন এস্টিমেট করে দিয়ে দেখি যে আয়রন সেটা তো কনফার্মেটরি, কিন্তু যেটা ইনভেসিভ আর কস্টলি, তো ইউ ক্যান তো আমরা করি না প্র্যাকটিক্যালি।
Absolutely not, Dr. Arpan. I want to point out that in this particular case, the comment on iron stores, the grade of iron stores on bone marrow is of particular importance. So please talk to the lab. It can be easily done. They can put up stains and they can easily comment on it's not a invasive or a costly test. It's routinely done. And if it is, I think it has been done already, go back and check your report. If it is not done, please do ask the lab to comment on the grade of iron stores. That would help you in clinching your diagnosis whether there is an underlying pre-existing iron deficiency anemia, as you pointed out. The second thing for this particular patient, he has come back. We're very happy looking at the hemoglobin of 10.6, but I am a little worried. The WBC count is 4,600 with a polymorph of 30%. So the neutrophil is coming to around 1,200, okay, which is not really normal. Neutrophil count is coming to around 1,200 to 1,300 for this particular patient. So keep a tab on him. Might be the parvovirus infection is not under control. Parvovirus commonly causes pure red cell aplasia, but it is also known to proceed to aplastic crisis. Like it can affect all the lineages. So just keep a close tab on this child. If you see like progressive cytopenias, you please do consider, like we can consider IVIG in this particular child. Okay,
Yes,
just keep a tab on the serial complete blood counts.
Okay, ma'am, we are asked to follow up after 2 weeks also. Then we'll check them out.
Thank you, Deepshika, highlighting the IVIG. I was just I wanted to ask her because we have seen the parvovirus and given the IVIG, and there is a dramatic response.
Yes,
there is
Yeah.
a failure and there is a dramatic response. So
Yes,
from IVIG, I think there is no controversy. At least it should be given.
One question, Arpan, in majority of cases, parvovirus infection is going unnoticed because there is a 2 weeks effect. Actually, within 2 weeks, red cell RBC count is high and RBC half-life is 120 days. Actually. And it does not usually affect. But in that cases, why it affects? Anemia is so severe.
আমাদের স্যার ডেটা দেশে ডেটা নেই, কিন্তু আমি এটা ইয়েতে দেখছিলাম ইউএসএ তে ওদের 50% লোকের ইয়েতে সিরামে মানে পারভোভাইরাসে আইজিজি পজিটিভ থাকে। সো মানে টু ক্রনিকলি ইনফেক্টেড হয়, কিন্তু এটা ধরা পড়ে না বিকজ মোস্টলি উই আর হেলদি enough. It is only significant those who have the reduced RBC productions or having some hemoglobinopathies like any sickle cell disease or other, or in case of iron deficiency, here the patient is already হয়তো হিমোগ্লোবিন ওর হয়তো 6-7 ছিল, তারপর পারভাইরাস অ্যাটাক করেছে যার জন্য হিমোগ্লোবিনটা কমে গিয়ে মানে 3 হয়েছে।
Yes, because in cases of healthy patient,
recover
not usually occur. But in case of PXS,
problem in immunocompromised and always there is a
Globinopathy is-
problem in the decrease in RBC production or increased destruction cases, RBC destruction cases.
Any other questions? What is, can you tell me what is the incidence of this type of this parvovirus induced anemia? Because we are not seeing so much, 2 to 3 or 4 cases. I think it's quite high. We don't think so.
আমি তো ম্যাম আমাদের বর্ধমানে লাস্ট 3 বছরই ফার্স্ট কেসই হলো। তারপর আরেকটা সিমিলার এরকম একটা পেয়েছিলাম, একটা বাচ্চা মেয়ে এসেছিল বোলপুর থেকে রেফার হয়ে।
So quite a lot we're getting.
তারপর ওকে বনমেলা করতে বলার সময় ব্যথা ভয় রাতের বেলায় পালিয়ে গেছে। এই পেশেন্টকে আমরা ট্রেস করেছি, একে ফোন নাম্বার আছে, একে ফোন করে আসতে বলি, আসেও। বর্ধমান থেকে খুব বেশি 30 কিলোমিটার দূরে বাড়ি, কিন্তু সেই পেশেন্টটা রাতের বেলায় চলে গেছে। মানে ওকে ব্লাড পেয়েছে রাতের বেলা, ও পরের দিন চলে গেছে। ওর হিমোগ্লোবিন অলরেডি আমার ব্লাড পেয়েছে, নেগেটিভ ব্লাড গ্রুপ ছিল, কিন্তু আমরা রাতের বেলায় চলে গেছে। এবং যে ফোন নাম্বারটা দিয়ে গেছে, সেই ফোন নাম্বারটা ফোন করে ধরছেও না, ফোন সুইচ অফ।
No, have you searched his literature? Have you searched
One thing I'd like to say, all the presenters and the residents who are joined.
এরকম নেই, তবে খুব এসে আনকমনও নয়। মানে ইনফ্যাক্ট এটা তো মোস্টলি এয়ারবর্ন ডিজিজ, এবং এটা আমাদের চেয়ে মোস্ট কমন এটা পেট থেকে আসে। বিকজ আমার নিজেরও পেট আছে, আমিও পেটকে পারোভাইরাল ইনফেক্ট ওকে ভ্যাকসিন দিতে হয় ওদেরকে। এবং ওরা খুব রিয়ালি আমার মানে 2খানা পেট মারাও গেছে যারা নিচে থাকে আমাদের কম্পাউন্ডের নিচে। তো ওদের খুবই কমন, মেবি ওখান থেকে ম্যাম ক্রস ইনফেকশন হয়ে যায়। কিন্তু আমাদের এখানে মানে হিউম্যান পেট খুব ক্লোজ ইয়ে থাকে।
So, যেটা তোমার last slide you said na, the rare disease is rare because we don't think of it. So especially like তোমার hemolytic anemia, somebody who is transfusion dependent, ধরো thalassemia, suddenly তোমার transfusion requirement বেড়ে গেল, বেশি anemic হচ্ছে, that is one case. Like you should be working up also for parvovirus. This parvovirus like the urethral aplasia is common in hemolytic anemia. So I think we can pick up more cases if we actively think of it and look for it.
যেটা ম্যাডাম বললেন আপনি, ওখানে থ্যালাসেমিয়া পেশেন্টে কিন্তু অনেককে আমরা দেখি হেপাটাইটিস সি ইনফেক্টেড থাকে। তো হেপাটাইটিস সি এগেইনস আ কজ অফ the মানে urethral aplasia. Hepatitis B and C also, most commonly C.
So it's a nice case, but I'd like to say that all the residents, please be concentrate on the clinics and try to give the diagnosis on the clinical finding basis of a history and the clinical finding. It should be justifiable. Whatever the differential diagnosis, why did you say the leukemia? Why did you say aplastic anemia? Why did you say that intermediate variety of chronic hemolytic anemia? You have to justify. And we used to say what are the points in favor of your diagnosis? What are the points against? The maximum points that will top the list. Minimum points that will be the bottom of the list. But it should be justifiable, huh? So method should be very strong. And the purpose of these classes are only to enrich ourselves and all the residents practicing pediatrician, the clinics, because this clinics is now forgotten, gradually forgotten, and no one is giving importance to clinics. So it's my and our effort to increase the clinics so that it will help you throughout your life. Theory and the practical theory will read and will forget. But if your clinics is strong, you are not going to forget anything. Okay, thank you. If you want to say any comments, last comment from last message from Dr. Taruk and Dipshika.
এক্সামিনেশন দেখে কিন্তু মাঝে মাঝে টাইমটা বেশি লাগবে বলে আমি এটাকে স্লাইডে ইনক্লুড করিনি। মানে হিস্ট্রি আর এক্সামিনেশন দেখে কি করে
Yeah, now you see chronic hemolytic anemia you have kept in the last. So it should be in the last only because it's the anemia, no points in favor of your diagnosis of chronic hemolytic anemia. So it should not be in the position of the third. Okay. There's no features of hemolysis, no features of chronicity. Then how did you say the chronic hemolytic anemia? There should be some pointers in clinical examination or history to keep in your differential diagnosis. Okay. So the last comments from, I'd like to have a comments from Dr. Taruk and then Dr. Dipshika, then we'll conclude the sessions.
Thanks, Orpon and other presenter, Dr.
Sabir, Dr. Sabir.
And Dr. Sabir, for your nice presentation and discussion all through clinics as well as some theoretical aspects. And I think it should be very much beneficial who attended and listen minutely and interact by question, and so and this type of Sandhya Pathshala is going on. I think I would also request our president to continue this session, monthly session. Thank you.
Thank you, Dr. Tarak. Now, the comments from Dr. Deepshika.
Thank you, ma'am. Both Dr. Arpan and Dr. Sabi, very encouraging to see if you have put in a lot of effort into the case, gone into the details, nicely presented. The slides were great. And you have also looked into the theory part. So very well done. Must congratulate both of you. You did very well. Your mentors too. They have definitely put in a lot of effort for this great presentation. I'm sure this has benefited all the participants, and this initiative is really great. I would have loved to have it during my residency times. So all of you try to attend. The ones that are not attending, try to encourage them to attend this. And again, the clinics part, you have to always go back to the ward and practice what you are reading up on the patients. That's the most important thing. You fumble during the exam time just to demonstrate basic things. Like I've seen residents fumbling, demonstrating pallor. They're not able to demonstrate pallor. They're not able to palpate the liver, the spleen. So just keep on, make it a habit to do it daily in your ward rounds. Then you'll be great at your exam. So all the best to all the residents. And ma'am, thank you. It's a wonderful initiative. Please do continue it. I had a great time. It was a learning experience for me too.
Okay, thank you. Thank you for your nice words, Dr. Deepshika. And now I'd like to request Dr. Swapun, if you are feeling well, then you can say a few words, because after taking a rest for 1.5 hours, you can say a few words.
Resist myself just glued to my chair and listening all the presentation and the expert comment like Dr. Deepshika, Dr. Tarak, and Shubhendu also. So it was nice, and I think this brainchild of yours will go a long way. And what Dr. Deepshika was telling about the clinics, we regularly feel it. The residents are very much reluctant to examine. They are much more willing to do the investigations and the theoretical part. So what the mentors are saying, you just have a look into it and do it meticulously. Do it meticulously. Medical line, the clinics is a must. Without clinics, you cannot go far away. So thank you. And I think our next Sandhya Pathshala will be again on a different theme, and it will be decided by Professor Datta. So good night, everybody. So we are concluding. Professor Datta, we are concluding.
Yeah. Thank you, Dr. Swapun. And it's a nice experience, and also learning for us also, revision for us also, and very interesting. And but I'm not satisfied, because thalassemia is such a big chapter. Only 20% has been discussed. I think it needs much more discussion, and it's a long discussion should be done, but in a limited time. So whatever we learn is a great learning. And but I will request all the residents from all the colleges, please volunteer for presentation of cases and join with this type of program. This is a totally clinical based examination. There is no testing of knowledge and nothing. It's a learning process, and medical, medical lines, all the clinicians should be lifelong learners. So we are all lifelong learners, and I request all the residents, please join in more and more. And I'll request all the faculties, please encourage your PGTs to present the cases. So that we can have a different cases, different system-wise cases, different cases and all. So thank you all for having a wonderful time. The Sunday time is a very good time we have spent for the last 2 hours. And thank you experts, Dr. Tarak and Dr. Deepshika, for your contribution. Thank you mentors for preparing the presenters, and presenters are wonderful. So thank you all, and thank you all the participants. Is very interactive, and especially Dr. Patro, the co-PGT, Dr. Malloy asked lots of questions. So we encourage it to be more interactive, and thank you all. I think now it's time to goodbye.
There was one question from Dr. Priyanka, that whether we can get